Hello there and welcome to the first of a series of e-learning modules that are going to be brought to you by the University of Bristol Medical School Pathology Society. My name is Lucas Brammer, I'm the current president of the society and I'm a third year medical student. Today I'm going to be talking about injury, inflammation and repair, and I'm hoping to keep it pretty brief and give you what are the basics of these processes because it's essential to understanding pathology in general. So by the end of this, hopefully you'll be able to talk about acute and chronic inflammation with confidence, describe some of the events that happen, we'll explain relatively briefly the role of the immune system in this process, and then identify some of the inflammatory markers that are actually used in clinical practice. And then finally we'll talk about the process of repair and what happens when actually there's some sort of persistent problem. So what is inflammation? Well, inflammation is the body's first line response to tissue damage. There has to have been some form of damage or what we call noxious stimulus to cause an inflammatory response. And usually that's a breach of either the skin or some sort of mucosal barrier. And inflammation's purpose is to eradicate whatever the harmful stimulus is. So it's its response at trying to get rid of whatever is causing the problem. And it's also a way of trying to limit the damage that's taking place and a way of initiating the tissue repair processes. Now it does involve the blood vessels, it involves cells, and it also involves a variety of chemical signals going between those cells to kick off all these processes. So we typically split inflammation into acute and chronic types, and this is purely based on the time span. So acute inflammation occurs immediately, it's a rapid response to injury, and it's mostly controlled by cells of the innate immune system. It's a short process because it can last for hours to weeks. Contrast that on the other side with chronic inflammation. There's some sort of persistent injury. There's some sort of persistent noxious stimulus that's causing a slow, gradual, mostly cell-mediated response from the acquired arm of the immune system. So things like lymphocytes. But also there's activity by macrophages as well. It's a cell-mediated process that can occur over weeks, months, or even years in certain cases. When inflammation is taking place, we use the suffix itis. And so, for example, that could be anything. Conjunctivitis, appendicitis is given here. So in order to put this into context, I'm going to give some clinical cases or examples of clinical cases. So here we've got Jack. Jack's 5 years old and one morning he's refusing to go to school, and it's not just because he's playing up, he doesn't feel very well. His mum has a look at him, he looks quite pale, he's sweating, she thinks he's got a temperature and he's complained of a really sore throat. So Jack's mum takes him to see a GP. GP takes a history and examines him, and when he looks inside Jack's throat, this is what he sees. Now the things that you can see on that image, it's quite red, it's inflamed, and those really big things at the back that are covered in white spots are the tonsils, and they don't normally look like that. They're usually not visible. And so you can see that's probably not quite right. Well, Jack's got, by the looks of it, an acute tonsillitis. An acute tonsillitis, by the information we know already, is an acute inflammation of the tonsils. That's told us that straight away. So he's got quite a high temperature and he feels quite sick. Now most tonsillitis quite commonly caused by viral illness, but here he's got these nasty white looking patches on his tonsils, and that makes you think that maybe it could be a bacteria causing this. So the GP takes a throat swab, and when he does, the results come back from the laboratory and they've grown these little strings of pearls under the microscope, and these are streptococci, and these are the main species that can cause a bacterial tonsillitis. It's usually Streptococcus pyogenes, an example of a group A streptococcus. Can a bacteria cause inflammation? Well, we've just seen it. Of course it can. It can release toxins, but also it triggers inflammatory processes through the molecules that sit on its surface membrane. Anything, pathogens such as microbes, bacteria, viruses, fungi, chemicals, trauma, radiation, all cause damage to the body, and they're all going to trigger that inflammatory response. So what's happened? Well, these bacteria have managed to get into the cells of Jack's tonsils. And as soon as there's some sort of damage, then the vessels immediately react, and the first thing they do is they actually constrict very briefly but then they dilate. What then follows this is that they become more permeable. And normally we manage to keep proteins, big proteins like albumin, into the blood. We manage to keep them in the blood. But what happens is, because the vessels become more permeable, the proteins leak out, and where protein goes, water will follow, because it will change the osmotic pressure. And so what happens is you get a fluid that's really rich in proteins. And those proteins are not only albumin, but they're things like antibodies, immunoglobulins. And so you get swelling up of the tissue. You get an edema as a result of that. And then what happens is, as well as the proteins being able to get out, we get certain cells of the innate immune system, mostly the polymorphs, referred to as neutrophils. And the neutrophils begin to perform phagocytosis and try and get rid of the infected cells. So that, in one slide, is exactly what happens in acute inflammation. And can we see this happening? Absolutely. We can see that the tissue's swollen, it's edematous. All of the interstitium has swollen up because there's fluid rushing into that space. Is it red? Well, absolutely. You can see particularly on my right, on the patient's left here, you can see that there's really red, nasty, inflamed tissue there. And that's because the blood vessels have dilated, there's an increase in blood flow to that region. And then what these little white spots are actually dead neutrophils. These are actually pus. And pus forms when you get a load of neutrophils that have fought the fight and then they give up and die. They've done exactly what they need to do and they die, and they form little collections on the surface of the tissue, and that's called pus, and it's horrible, it smells horrible. And we can sometimes call inflammation that causes pus formation, we can sometimes call that suppurative inflammation, but that's a special type of acute inflammation. So what happens in the cells then? We talked a lot about the way the fluid moves, the way the vessels work, etc. But the predominant cells that are involved in acute inflammation are neutrophils, and you might see these confusingly referred to as polymorphonuclear cells, granulocytes, granulocytic neutrophils, etc. It all means the same thing. They're also a type of white blood cells, so sometimes people grossly refer to them as leukocytes. But that covers any type of white blood cell. This is specifically now talking about neutrophils, which are also capable of phagocytosis. So the whole thing gets tremendously complicated. But essentially what happens first is, because the vessels become more permeable, you lose a lot of fluid, and so the blood flow slows down. So there's more chance for a start that the neutrophils are going to be wandering past quite slowly and then realizing there's a problem. But the first thing that happens is these neutrophils attach themselves to the lining of the vessel, the endothelium, and they do this using very special molecules called integrins and ICAM and all these cellular adhesion molecules. So beta-2 integrin is an important one, and ICAM, which is a cellular adhesion molecule, attach them, anchor them to the endothelium. And then what happens is this really groovy process of diapedesis, where the neutrophils clamber their way through the gaps in the endothelium. What then needs to happen is, when they've squeezed through the vessel wall, or migrated through, they need a signal to attract them to where the problem is. And the cells give off chemicals that then attract neutrophils towards them to begin that phagocytotic process. And that process is called chemotaxis. So to sum all that up in a little slide, blood flow slows down, the neutrophils attach to the vessel's walls via the integrins and ICAM, etc. They then migrate through the vessel wall, which is called diapedesis, and then they wander over by a diffusion gradient, a chemical diffusion gradient, toward the infected cells. They also recognize cells that are infected, and this is really a bit of an immunology topic, but they recognize cells that have been infected because they've got special markings on their surface, and they're called opsonins. And an opsonin basically identifies a cell. It's a little flag that says, I am infected, or I am a dangerous cell. And opsonins come in various different forms, from complement to antibodies. The Fc portion of an antibody can act as an opsonin, etc. So when you look down the microscope, it should come as absolutely no surprise that the first thing you see in acute inflammation are a load of polymorphs, loads of neutrophils. So there's loads of neutrophils all scattered around in that slide. There are so many neutrophils there. It's just a party of neutrophils. And all those white arrows are showing you these multilobulated nuclei that you see in neutrophils. So what do neutrophils do? They perform that process of phagocytosis that I've not really put too much in on this, because essentially all it is neutrophils literally eating the damaged cells. And they form these pseudopods, they engulf it, and bam! Once they've got them inside, they either break them down through enzymes, which is oxygen-independent killing, or they use oxygen-free radicals and a big whoosh of oxygen-free radicals to blow up whatever the organism is. So how does the body respond to an infection? Well, the first thing that would obviously come to our minds is the fact that we're going to have more neutrophils. Because if we've got a battle, we've got to increase the number of soldiers. So some of the first things that you see will be leukocytosis, which is an elevation in the white cell count. But even earlier than that, you'll see a response from the liver. The liver is very clever, because what it does is it releases these things called acute phase proteins, and these assist the immune system in the eradication of microbes. And they produce things like C-reactive protein and ferritin. Now, C-reactive protein is important because it performs that role of opsonization that I just told you about. And ferritin binds iron, and bacteria and microbes love iron. They need it. They really, really need iron. So if you take it off them by synthesizing ferritin, which can bind iron, then what happens? They all die because they can't get their iron, and they all cry. C-reactive protein is frequently used on the wards, and if you're on a clinical attachment in any sort of acute medical ward, then you will hear people saying, what is the CRP? And the CRP is released during that inflammatory response, so it's a marker that there is some sort of infection, and when it's up, that's indicative that there's been this acute phase response, that there is acute inflammation taking place. And when the patient comes in, they record what the CRP is, and then when you start to give them their antibiotics or their antifungals or whatever, then you take the CRP again. And if it's gone down, then it means that the infection is sort of being attenuated. If it doesn't change, then we might have to think about something. So what it's useful for is for monitoring responses for treatment and as a baseline to therapy. So, chemicals. We also mentioned that chemicals are really, really important in inflammation. And there are so many different chemicals that are involved in it. It'd be impossible and a waste of time and an incredibly boring waste of your life to try and learn them all. So the cytokines that are really important. Cytokines are chemicals that cause a response in another cell. And they usually cause quite amplified responses in cells. And the ones that are really important in inflammation are things like tumor necrosis factor, interleukin-1 and interleukin-6. They're all pro-inflammatory, so they will trigger a lot of the processes that we've talked about, things like vascular dilatation and etc. Complement is something that's for the immunologists to deal with, but that's essentially, when we talked about opsonins, that's a form of complement. Kinins, again, chemicals. Histamines, very important in activating things like mast cells and releasing all sorts of pro-inflammatory cytokines. And then leukotrienes and prostaglandins, and I am going to separate these ones because aspirin, which is a really important drug, acts by inhibiting the synthesis of a certain type of these. So what happens in acute inflammation is an enzyme called phospholipase A breaks down membrane phospholipids into arachidonic acid. And then it can then go one of two ways. Either it can be converted into prostaglandins by the COX enzyme, or it can be converted by the lipooxygenase enzyme into leukotrienes. Now, try and forget about leukotrienes for now, but they're there. But prostaglandins and leukotrienes are both pro-inflammatory. They cause things like attraction of neutrophils, dilation of blood vessels, etc. But prostaglandins are also really important in the secretion of gastric mucus and the protection of gastric linings, which is why when you give aspirin and it inhibits the cyclooxygenase enzyme, the COX enzyme, that prostaglandin production goes down, and that's great for inflammatory pain, but it's also really rubbish for the gastric mucosa. We mentioned in this case study that our patient had a sore throat, and that's because of the death of the cells, etc., that's taking place. But really what happens in inflammation, you get swelling, you get redness, we've talked about that, you get pain and a reduction in function. And the pain is caused by all these cytokines and nasty chemicals being released that are causing so much damage to what are harmful cells, but it also irritates the nerve endings that cause pain. Now, aspirin is a very good painkiller for inflammatory pain because it's going to stop some of the prostaglandins from irritating the nerve endings. So the main points on acute inflammation are listed here, and basically its response to noxious stimuli is short-lived. There's a transient vasoconstriction followed by vasodilatation and increased vascular permeability, so you get that redness or erythema, posh name for it. An exudate, which is a protein-rich fluid, leaks out and causes edema or swelling, and leukocytes, white blood cells, move into the tissue and begin the innate cell-mediated immune responses. Chemical mediators attract the cells, trigger further responses, irritates nerve endings, and you get pain as a result of that. So I don't think I mentioned the word exudate, and that's really, really important. But the fluid that leaks out from the vessels is rich in protein. And any fluid in the body that's rich in protein is referred to as an exudate. Anything that's got a very low protein content is referred to as a transudate. So, sorry, I didn't quite make that as clear as I wanted to. So what happens in chronic inflammation then? Well, more or less exactly the same processes, but it's a persistent response by the body, and it can last weeks, months, or years in chronic disease. It's a response that's actually controlled by monocytes and macrophages and lymphocytes, and the macrophages effectively take on the role that the neutrophils did, because macrophages are really good cellular killers. And where people get confused is what's a monocyte, what's a macrophage. Monocytes are found in the blood. When a monocyte moves into a tissue from the blood, it becomes the macrophage. So monocytes are the precursors or prologue to the macrophage. They are the part 1 to the part 2. And lymphocytes are part of the acquired immune system. And the ones that we mostly see are plasma B cells. So they're a type of B lymphocyte called plasma cells, which is the very end of the line in terms of B cell. You might also have this phenomenon called fibrosis, where there's lots and lots of collagen being laid down. And that's essentially filling the gaps of where old tissue, old cells used to be. So it means that you get a tissue that's not actually as good as the one was before. So what can trigger it? Well, for some reason foreign bodies pops up first, and it's true foreign bodies can, but and that's things like bone, even though it's not foreign to you, it is to the tissues that it falls in. Autoimmune disease, where there's persistent attack, so the key word here is persistence, and where there's a microorganism that just won't go away. So we've got a case, John's 59, he suffered from pain in his abdomen frequently over the last 10 years on and off. And he's been told that this is mostly irritable bowel syndrome, nothing to worry about. But recently he's been having more pain than usual, and his bowel habit has changed, and he's now been vomiting. It's not good. Anybody that's got a change in bowel habit, and at this age, is edging on what we call the National Bowel Cancer Screening Program. So this should be ringing alarm bells. And for some reason, John has a CT scan first, but we'll get around to that. It's not really a clinical presentation, so there we go. But what you can see in these images, all the arrows are showing you, the red arrows are showing you where there's spots of inflammation. And what they're pointing to is the bowel. They're pointing to the small bowel. And what you can see is that it's very big, so it's dilated, it's full of stuff, and the walls are very thickened. So what the yellow arrows point to are the thickened walls, and the red arrows point to spots of inflammation. So you're getting stricture formations where the red points are. So as well as a scan, John then goes and has an endoscopy. So he's had both done because they were quite concerned what was going on. And so a histopathologist gets samples of his tissues, they cut it up, have a look at it, and then look at it down the microscope. And what they see is this. Now normally the colon should be full of glands. Should be full of glands. The bowel should be got lots of glands that are secreting stuff in and out of it. But what we're seeing here is not that. We're seeing almost complete destruction of the tissue. That's happening through the whole wall, and Crohn's is characterized by this thing called transmural inflammation, where there's inflammation across the whole wall. And you can see some glands in there, which are the little round bits, but mostly there's lots of dark blue dots, and that's plasma cells and inflammatory cells all in there. And what you can then see are these little pale regions here. And these are regions where the process has just essentially gotten too much. And so the macrophages have all bundled up together and grouped up and said, right, what we're going to do is we're going to tackle this together, boys. And as a process, they form something called a granuloma. Now this is a very specific type of chronic inflammation. But granuloma are formed when you get a collection of modified macrophages, and they're called epithelioid histiocytes. And they essentially wall off an organism or some sort of process that's become too much. It doesn't have to be an organism. And it's a special type that's seen in autoimmune diseases, such as Crohn's disease that this gentleman had, and mycobacterial infection. So that gentleman had a disease called Crohn's disease, which is a chronic inflammatory bowel disease. And it's an example of chronic inflammation. It's something that is there all the time, and we're still not sure what causes Crohn's disease. But it gets that bad that you get these situations where you get complete inflammation of the wall. And what happens in chronic inflammation is eventually you get the formation of this fibrous tissue because of the persistent inflammatory response. And what happens as a result of that is you get thickening of the wall, and that obviously blocks off the bowel, and that can cause symptoms of an altered bowel habit. It can cause an obstruction, and it can mean that a patient has to go to surgery to have the bowel removed. So it is a very, very serious disease and can be actually very debilitating for patients. It's a very good example of chronic disease, chronic inflammation. And where else you see this is in TB, because in tuberculosis, the bacteria that causes tuberculosis is a mycobacterium, and it's got something in its cell wall called mycolic acid, which is why it's called a mycobacterium. And what that does is essentially protects it from the immune system. It's very, very good. And so that's very, very bad for all the inflammatory cells. So they try and gang up on it, and it just can't happen most of the time. And you see these granulomas forming, but they're special forms of granulomas where you see a central bit of caseating, cheesy necrosis. So what happens in order for tissues to repair then? Well, if there's been relatively low-grade damage, so a nice clean cut, then you get the inflammatory response, and you get the formation of this fibrous granulation tissue. Now what granulation tissue is it's just basically collagen that's being synthesized by fibroblasts. So the fibroblasts are spitting out lots of collagen in order to form a new scaffold for the new cells to form on eventually. And you get some new blood vessels, you get angiogenesis as well. So this is essentially a repair process that's going on. And then in that sort of situation, in a surgical wound, you would hope, if I don't get infected or anything like that, that you get complete union. And by that we mean that the break comes together and it's repaired. Where there's been much more extensive inflammation, high-grade damage, then there's an intense inflammatory response that tends to persist even when that granulation tissue is being formed. And it persists, it goes on, you get a lot more blood vessels forming as we try and combat all that that's taking place. And what then happens is you get scar tissue, because there's lots and lots, there's excessive amounts of collagen deposited, and it results in something called wound contraction, where the two sides are literally pulled in and it sinks down. And this slide is showing you a slide of scleroderma. And what that is an example of is where you've got this fibrosis process. And fibrosis is something you'll come across a lot in clinical practice, because you will see fibrotic lung disease, where there's fibrosis in the lungs. But what all fibrosis is essentially accelerated repair mechanisms, accelerated deposition of collagen, just persistent deposition of collagen. And that collagen is great, but it's relatively rubbish if you start depositing loads of collagen in the lungs where the alveoli used to be. Collagen is great, but it's relatively useless if you start depositing a load of collagen where there used to be cells that line the bowel and absorbed stuff, because collagen can't do that. So fibrosis can be incredibly detrimental to tissue. But that tends to happen in responses to long-lasting chronic inflammation. So there's one thing I want you to take from this. Acute inflammation is a short-lived process. It's a short, fast process. It's a rapid response to cellular injury. Chronic inflammation is a prolonged form of inflammation that may often result in fibrosis and irreversible tissue damage, essentially. But not always. So that's been the first in our series of little e-learning modules. I hope it's not been too long. I hope it's been okay. If there's anything I've said that sounds like a load of rubbish, or you really want to question, please put a comment in the comment section and get in touch with us. Other than that, I hope you'll watch the next one. Thanks very much.